I thank Dr. Gigi for giving me this opportunity. This Ataxia, where is the clue, is obviously Gigi's title. There are 4 cases here. 2 are spotters and 2 are slightly difficult. 2 are treatable, 2 are not treatable. So the first case, a 57-year-old gentleman presented with decreased vision since young age, drooping of eyelids since childhood, abnormal movements for 3 years and swaying while walking for 3 years. So this is his video. As you can see, his eyeballs are nearly frozen, hardly any movements, complete ophthalmoplegia. Pupils were normal. Oh, there's no audio, but he has to look to up, right, left, etc. There are no eye movements.
Stop.
And a severe dystonia of the neck also.
ഇനി സപ്പോർട്ട് കൊടുത്ത കഴുത്തിന്
Once he supports his neck, there are no movements.
ഇനി സപ്പോർട്ട് മാറ്റിയേ, വീണ്ടും സപ്പോർട്ട്. ശരി, തിരിച്ചു നടന്നേ.
Coordination as well. So to summarize, he has blindness due to decreased vision due to bilateral optic atrophy. He has external ophthalmoplegia. He has generalized dystonia and ataxia. Since childhood, ataxia was the last to come. So based on this, it looks like we thought it was a very difficult case. The eye movements, if you think the progressive external ophthalmoplegia was the cardinal feature, then you would probably think of a mitochondrial disorder. If you thought that the dystonia was the cardinal feature, you might think of disorders like NBIA. And ataxia was not in the forefront, but spinocerebellar ataxia also was a consideration. So his mitochondrial genetic study was normal. His MRI showed a superior vermian atrophy. Genetic study showed a mutation suggestive of spinocerebellar ataxia type 28. So spinocerebellar ataxia type 28 is a very rare disorder. The only features are gait ataxia with, and the hallmark of SCAR28 is of ophthalmoplegia, as you saw in this case. The dystonia what we saw was not a usual feature of SCAR28. So if you look at scars, it is very difficult to diagnose all these scars clinically, but there are some scars which have typical clinical features. For example, scar 7 has retinal degeneration. Scar 7 is the only scar which has retinal degeneration. And scar 36 is a very striking disorder which has tongue fasciculations and bilateral sensory neural deafness. I think one of our CAN BG teaching courses we had a case of scar 36. Then scar with ichthyosis is suggestive of scar 34. Scar with myoclonus is scar 14. Scar with chorea is everyone knows scar 17 resembles Huntington's disease. Then scar with ophthalmoplegia to this degree is seen in scar 2, 3, 28 and 40. So that was scar 28. That is not possible. It was impossible for us to diagnose that case. Now second case is more common case. I think many of you might diagnose it. This 42-year-old man had intellectual disability from childhood. He was having seizures infrequently, and he was on phenytoin, and he was diagnosed as cerebral palsy with mental retardation and epilepsy. On phenytoin, he developed cerebellar ataxia and cerebellar dysarthria. And phenytoin was stopped and he was switched to clobazam, but there was no improvement in ataxia. So in summary, he has epilepsy, intellectual subnormality, ataxia. But he had a diagnostic clue on clinical examination, and that clue was this. Yes, all of you know. These are tendon xanthomas. These are fleshy swellings seen on the tendons. This was seen in the foot. The next history you would like to ask is history of cataracts, which are very typical for CTX. And next clinical examination you would like to do is to palpate for tendon xanthomas of the Achilles. and he had Achilles tendon xanthomas, which I cannot show here. He also had history of bilateral cataract surgery 4 years ago. So classic triad of CTX is juvenile cataracts, neurological findings, and tendon xanthomas. This is the height, average height. This MRI showed cerebellar atrophy and white matter changes in both the cerebellar hemispheres. This genetic mutation, genetic study showed CYP27A1 mutation suggestive of cerebrotendinous xanthomatosis. So CYP27A1 mutation codes for a gene called serol27 hydroxylase, which affects the cholesterol pathway, and this leads to accumulation of abnormal bile acid alcohols and cholestanol. And cholestanol gets deposited in brain, which produces Mendel's abnormality, epilepsy, and in cerebellum it produces ataxia. In spinal cord it tends to produce hyperintensity of the pyramidal tract and posterior column, similar to B12 deficiency and retromyelopathy. And peripheral nerves it may produce mild peripheral neuropathy. In tendons it produces tendon xanthomas. Chronic diarrhea is a feature in children in childhood. Bilateral juvenile cataracts also in starts from childhood. In fact, chronic diarrhea with bilateral cataracts in childhood, the diagnostic condition you have to suspect is CTX. And blood vessels it may get accumulated, it may produce stroke and MI. This is from the literature. This is spinal xanthomatosis, also a condition which produces hyperintensity of the lateral corticospinal tract and the posterior column. And CTX is a treatable disorder. It can be treated with chenodeoxycholic acid 750 milligram per day. Third case is a spotter. One 30-year-old lady with ataxia. The sound.
Mukile. Verella. Mukile. Verella. Mukile. Verella. Mukile. Verella. Mukile. Verella. Mukile. Verella. Mukile.
Slow saccades.
Verella. Mukile. Verella. Mukile. Verella.
You can see the eye movement of that patient when the saccades are examined.
Verella. Mukile.
Saccades are
Verella.
fast movements.
Mukile. Verella. Mukile. Verella.
Okay. Another spotter case with അങ്ങോട്ടും ഇങ്ങോട്ടും നടന്നു. അങ്ങോട്ട് നടന്നു.
വലത്തോട്ട്
അവിടെ നിൽക്കും.
എടുത്തോട്ട്
ഒരു കാലിൻ്റെ മുമ്പിൽ മാറ്റി. എൻ്റെ വിരൽ നോക്ക്. ഇങ്ങോട്ട് നോക്കി. ഇങ്ങോട്ട് നോക്ക്. ഇങ്ങോട്ട് നോക്കി. നീ ഇങ്ങോട്ട് നോക്കി. അങ്ങോട്ട് തിരിഞ്ഞ് നിൽക്കും. ഒരു കാലിൻ്റെ ഇങ്ങോട്ട് തിരി. ഒരു കാലിൻ്റെ മുമ്പിൽ മുകളിലോട്ട് നോക്കി. മുകളിലോട്ട്. Play this video again.
വലത്തോട്ട്
Everyone will diagnose.
വലത്തോട്ട് എടുത്തോട്ട് സ്പീഡിൽ
മാറ്റി. എൻ്റെ വിരൽ നോക്ക്. ഇങ്ങോട്ട് നോക്കി. ഇങ്ങോട്ട് നോക്ക്. ഇങ്ങോട്ട് നോക്കി. Multiple sclerosis.